Hello, everyone. Happy Friday. Welcome to yet another RLR. We start with the small junior R, and then Big Prof Raz will join us in a few moments as he transitions from one meeting to another. Remember, Big Prof Raz is a compliment. He calls himself Big Prof Raz, and if you've ever met him in person, you'll see why. But as we wait for him to arrive, I'm thrilled to share that we have another case presenter mentored by our beloved Alec. Lizzie is joining us today. Lizzie, do you want to tell us a little bit about yourself?
Sure. Good morning, everybody. I guess good afternoon. Well, still 11. Good morning. I'm Lizzie. I'm a fourth year medical student at Baylor College of Medicine in Houston, Texas. Really excited to share my case with you guys today.
Fourth year, huh? How's it been so far?
It's been pretty calm. We're on like summer break right now, so just kind of hanging out, getting ready for applications.
How much time off do you have?
We get 2 weeks, so that's pretty nice.
I mean, that's awesome. That is so neat. That's funny because I just came off a 2 week vacation, and today's my first day back. So I hope you've been relaxing just as much as I got to. It was really neat. Prof Rez is here. Hi, Prof Rez.
Good morning. Welcome back, Robbie.
It's really nice to be back, Prof Rez. I noticed that your mic sounds different than it usually does. It's a little bit.
Oh, nothing has passed our main diagnostician.
Well, Lizzie, while Prof Rez works on his mic, do you mind telling us a little bit about yourself outside of medicine?
Sure. Some things I like to do outside of medicine. I like to work out. I'm into CrossFit these days. I have this like CrossFit tournament type thing in October that I'm training for, so I'm really excited for that.
That sounds really cool. I bet you got the biggest smile out of Deborah, who's also loving the CrossFit life. But I will tell you, the CP Solvers is full of people who are workout obsessed, and Elena has started a has started an incredible initiative, which I am embarrassed to say that I don't fully comprehend, but that's definitely a lesion is me, not anybody else. And Lizzie, do you know what you're going into medicine wise?
Yes, I'll be applying to internal medicine this summer and then not really sure what I want to do inside internal medicine. I love just like general practice, so kind of leaning towards hospitalist right now.
Sounds so cool. I think Prof Rez will be very happy to hear that as a hospitalist himself. Prof Rez, good morning. Let's take two. There you go.
I feel like you would be such a good radio show host, the way you're just like juggling, my mic not working, this, that. By the way, at 9:30, I'll have to take a brief intermission because I'm covering a colleague
Yeah,
for 5 minutes.
sounds
Uh,
good.
but yeah, that's awesome, Lizzie. So cool that you're in that space, that CrossFit space. Hopefully your case today stretches us out. And whenever you're ready, please, we'll get the whiteboard going, the recording going, and I'm gonna ask Robbie to discuss the first aliquot because it's been forever since we've heard his voice
Oh, Prof Rez, no,
about
I must
medicine.
decline
No,
your
I
offer.
insist, Robbie.
All right, you got it, Prof Rez.
Alrighty, I'll go ahead and get started. So our chief complaint today, we have a 38-year-old female who's presenting with 3 weeks of progressive left-sided chest pain, shortness of breath, subjective fevers, and chills. So to kind of give you some information on the HPI, her chest pain is left-sided, sharp, and it's worse on deep inspiration. Her shortness of breath is constant, but it worsens with exertion. And she has a cough, but it's non-productive. She endorses some like mild nausea, decreased oral intake, and generalized weakness. But she denies any like recent upper respiratory tract infections or sick contacts. And then she presented to the emergency department because she had some intolerable shortness of breath. And then she was found to be satting at 88% on room air. And that's the end of the first aliquot.
Lizzie, I really appreciate that entire journey from hearing that this has been going on for some time. Do you mind reminding me how many days she's been having symptoms?
She's been having symptoms for about 3 weeks. So
3 weeks. I think that's really helpful because I love your very deliberate choice to tell us this has been a story that's been going on for 3 weeks, but it has reached a crisis point, and that there is now not just shortness of breath or chest pain, but there is lung compromise, and that lung compromise in the form of hypoxemia. So now this is not just chest pain, shortness of breath, this is respiratory failure. So all that I will do is to try to articulate the difference between these things that are actually commonly merged together, and the value of their uniqueness is not easily appreciated. So three things: we have chest pain, we have shortness of breath, and then we have hypoxemic respiratory failure. So what does chest pain fundamentally mean? It fundamentally means that there's something in the thorax that hurts. And it really is an incredibly broad range of possibilities, from something as life-threatening as a heart attack to something as benign as a pulled muscle after an intense prof res workout. Both those things are very, very possible. What is the probability of a patient coming into the ER and being discharged with chest pain? In all comers, it's about 90%, which tells you the vast majority of chest discomfort is often at the surface of the thorax and often benign. What about shortness of breath? How many benign dischargeable conditions are there of shortness of breath? Much, much, much less. Shortness of breath implies that something inside the chest often is dysfunctional. And it's often dysfunctional in a serious manner, especially when the patient has had their shortness of breath limit their exertional capacity. Now, there are some benign conditions that cause shortness of breath, benign defined as not acutely life-threatening, including deconditioning, me at the end of my run, or somebody in the midst of a panic attack. But you'll see that the list of causes of shortness of breath is much, much, much lower of benign causes. What about hypoxemia? Hypoxemia, actually, let me just step back. Chest pain, the whole chest is on the hook. Shortness of breath, the visceral organs. Hypoxemia localizes the disease definitively to something wrong at the microscopic level between the conversation of the alveolus and the blood vessel. So chest pain is basically the whole world in the thorax. Shortness of breath is what's often the thorax contains on the inside. And then hypoxemia is zooming in at a massive level and existing at the alveolar vascular interface. It's like, honestly, being skydiving is shortness of breath, and you have this massive world beneath you. Dyspnea is you're flat on the Earth's surface, and hypoxemia is you're at the molecular level. And so the question that we have to ask here is, what is wrong with this patient's either alveolus or what is wrong with this patient's blood vessel? And an alveolus can either be filled with something or collapsed by something. And a blood vessel is either diverted, i.e. shunting, or obstructed. All the things that you can think of that cause hypoxemia result from alveolar filling or from alveolar collapse, vascular filling with a thrombus, or vascular shunting. So that's the big picture. Prof. Rez, I'm really curious what you're making of the more sort of zoomed in data that we have.
All I'm lamenting is why Lizzie didn't give you one more concern to add into your macroscopic, microscopic, minuscule at this I really have nothing to add, but except just the fevers and chills. So like everything that Robbie said, we're in the thorax. Now we have like an inflammatory thoracic syndrome. And maybe the hypoxemia allows us to even prioritize amongst like the lungs, the heart, the mediastinum within the thoracic cavity. And it's easy to imagine like the heart is inflamed and you have buildup of edema causing hypoxemia, but equally easy to imagine that you have something happening in terms of inflammation of the lung parenchyma or even the blood vessel that leaves the lung parenchyma, like a pulmonary embolus. So I think it's crazy how much progress we've made with like your breakdown of chest pain, shortness of breath, hypoxemia. Then you sprinkle on it some inflammation. And now we're running to see which part of that organ in the lung likelihood, by all likelihood, or the heart is inflamed. Lizzie, back to you, my friend.
Awesome. That was a great discussion. So I'll go ahead and just round out the rest of the history. So we have no past medical history. For medications, she's just been taking Tylenol to help with the fevers. For family history, she doesn't have anything that she can think of. And then for social history, she lives with her husband. She works in a plastics manufacturing company and doesn't have adequate access to PPE or like personal protective equipment. For health-related behaviors, she has no alcohol or drug use, but she's a prior smoker with about 30 pack year history, but she quit 8 years ago, and she doesn't have any allergies.
Is this alcohol too, Lizzie?
Yes, that'll be the end of it.
Okay, sweet. I'll comment here, and Robbie, feel free to layer on anything. I'll say this, like, when we were first discussing these cases, how old were we? We were in our 30s, right? Early 30s, late 20s. Now I'm older than the patient. And so that really cements that this patient is like previously healthy. Like there's no, oftentimes when someone's older and the presenter says no past medical history, and we're like, oh, no past medical history doesn't mean no known history. I'll tell you, this is no past medical history. Like there's no reason for someone this young to be seeing a doctor regularly. In fact, I don't have a primary care, and people yell at me for that. But now I want an X-ray of my ankles. I have to establish a primary care doctor. All that is to say this, Lizzie. Like I think I have a young woman coming in with an inflammatory thoracic syndrome that's subacute and progressive in nature. And I think what gets prioritized, it can be anything, but you have to consider autoimmune etiologies like lupus. Additionally, in all comers, but it's more so younger people, like knowing their immune status is very important because they just haven't been in the healthcare system. They may be involved in behaviors that may give them increased predisposition to viruses like HIV. So I'm already triggering my mind. I need an HIV test. And this history, like that she works in a plastic manufacturing company, if I'm being completely authentic, like I wouldn't have even acquired that. Like maybe I would have acquired it, but I wouldn't have asked about PPE. Like I know this is a case format. So of course, there can be exposures and hypersensitivity pneumonitis, but I'm going to table that for now. After having said that, I'm going to put it aside and we'll track it in case it becomes relevant. But really, what this does for me is just confirms that she's previously healthy, needs an HIV test, is at risk primarily of autoimmune, infectious, and exposure related etiologies. So, Robbie, anything else to layer on that?
Nothing, but I will this time actually mean it and not say anything else. My nothings are often followed by some form
I
of
love how we're just
nonsense.
sharing, like we're doing a meta. We're like, there's like an internal dialogue within it. It's starting to become like an Inception episode where we're just like, right now, I'm thinking about breaking this down into chest pain and shortness of breath. So how I'm going to do that is first I'm going to say the chest pain. Now, chest pain is very
Oh, Lizzie, please save us. What do you have next?
I gotcha. So now we'll dive into the exam. So for temperature, her temperature is 102.4 degrees Fahrenheit. Heart rate's 131. Blood pressure 121/59. Respiratory rate 28. And then she's satting 89% on room air. For the exam, overall, she's like not in any acute distress. She's well developed and well nourished. For Hint, her head is normocephalic, pupils are equal, round, and reactive to light, and she has good dentition. For cardiovascular, she's tachycardic, has normal rhythm, normal S1, S2, no murmurs, rubs, or gallops, and no JVD. And then for her pulmonary exam, she has decreased breath sounds over the left lower lobe. And for abdominal exam, she had soft, non-distended, non-tender. Neuro was overall within normal limits. Same with extremities and skin. No lymphadenopathy and no new rashes. And we'll stop there.
Lizzie, by the way, this is just absolutely outstanding presentation for many reasons, in large part because of how concise you've been able to be and really focus the case on the pertinent data. And I think on vitals and exam, there's two key pieces of pertinent data, which I'll reflect on and then pass the mic to Prof. to see what else I've missed. And so when you look at those vital signs, you see that she's septic and she's very sick. And so this patient will immediately qualify for empiric antibiotics because she meets one of the 4 conditions where we empirically treat patients before we know what they have: septic shock or sepsis, neutropenia, decompensated cirrhosis, and one other one, which I'll actually skip over for now. It might be relevant later. But so she's septic here, empiric antibiotics. And the question is, what is the source? And I think that's where we have to be a little bit more thoughtful. Now, you might think, well, why do we have to be thoughtful? The reason we have to be thoughtful is, well, you might think, why do we have to be thoughtful? This is a respiratory focus. And the goal of this conversation is to articulate one piece of nuance about what it means to have a respiratory focus, and that how might that change your empiric antibiotic therapy. So we know that she has decreased breath sounds in the left lower lobe. Now, what does that mean? That means that there's something in the way of your stethoscope and her lung sounds. What could that be? 2 things: fluid or air in the pleural space. Air is unlikely to be super infected. Of course, you could have air and fluid. That's called a hydropneumothorax. But because of the presence of inflammation, the fluid is likely, the presence of inflammation prioritizes the fluid over air. So this patient has, to some degree, a pleural effusion, which is very compatible with the history that she has of pleuritic chest pain on that side. Now, a pleural effusion in the context of fever and tachycardia should be an empyema until proven otherwise. So when you look at this and you're like, oh, my exam is telling me that this is an empyema, of course, the exam is not good enough to be confident about that possibility, but it does change your empiric antibiotic strategy. In patients who have a respiratory focus of infection, covering anaerobes is almost always unnecessary because oxygen kills the anaerobes. But there are 2 places where oxygen in the respiratory system does not get to, and that's when you have a contained lung abscess, where oxygen cannot penetrate that abscess, and when the infection is in the pleura. And so here, empiric antibiotic therapy that does not cover anaerobes would be probably insufficient for this patient. And so something that I would consider is piperacillin tazobactam, ampicillin sulbactam, along with gram-positive coverage. So I think that the nuance here is when you have suspicion of either sepsis physiology in the context of a lung abscess or an empyema, you should adjust your empiric antibiotic therapy for CAP by incorporating anaerobes, which are a common offender in empyemas. Now, the question is, does she just have an empyema? And I think the answer to that is no. How can you have a pleural process in hypoxemia? The most common reason you have a pleural process in hypoxemia is the pleural process is pulmonary edema. And the pleural process is a cardiogenic effusion. And there's a separate process causing the hypoxemia, and that's fluid in the pulmonary vessels. A pleural effusion inherently should not cause compromise of the alveolar capillary interspace unless the effusion is so big it's collapsing the alveoli. So here, either she has a separate disease process causing hypoxemia, or she has such a large effusion she's causing significant alveolar collapse, or she has a parenchymal pleural disease, such as a pneumonia that has gone into the pleura, or heart failure that's affecting both the lungs and the pleural space. So there was a lot. I think the most important thing here is to suspect a pleural effusion and to add anaerobic coverage to your empiric therapy. And the rest, I think we have time to tease out. But I'm curious what other thoughts or wrinkles came up for you, Prof. Rez?
Honestly, not Robbie, if this patient came to your ED and you like quickly evaluated them and put yourself in Lizzie's position, would you go straight to the CT scan?
Yeah, you know, Prof. Rez, as you know, my POCUS skills are not good, with some exceptions. I'm comfortable with doing a point of care ultrasound for ascites and point of care ultrasound for a pleural effusion. So I would probably do a POCUS. And in doing a POCUS, you could probably see if there's an effusion and if it looks inflammatory. And if there's no effusion, then I would doubt my exam and I would just stop and get an x-ray and see what's going on. But if there's an effusion, I would go straight to a CT scan for sure. What about you?
Yeah, I mean, all likelihood, this patient's probably going to get an X-ray first, but I already have a sense that I want like better characterization of the pleural parenchymal space. And so not only would I get a CT scan, I may even consider using contrast because if like, yeah, like there's a possibility, and I think care of patients with lupus that have pleural pathology, but also have a PE because of that hypercoagulable state. Not to say this is lupus by any means, but I'm just trying to think steps ahead. And there's no probably going to be no contraindication to that. And so with one study, you get so much value and bang for your buck.
I couldn't agree more, Prophet. All right, Lizzie, tell us more.
Alrighty, well, we do have a CT, but I'll give y'all labs first. So for hematology, her white blood cell count was 24.7 with a neutrophil predominance at 91%. Her hemoglobin was 11.5 and platelets were 513,000. For chemistry, the complete metabolic panel was only really notable for a total protein of 5.5 and an albumin of 2.6. The rest was within normal limits. Her LDH was 316 and lipase of 4. They also got a VBG due to the hypoxemia, and the pH was 7.39, PaCO2 was 43, and the O2 was 40, and her lactate was 2.1. They sent for coags. Those were all within normal limits. And then for her infectious workup, her respiratory viral panel and HIV panel were negative. Strep pneumo and Legionella antigens also negative. And then her blood culture was negative. Then for imaging, they did get a chest x-ray first, and that showed a large left pleural effusion with near complete atelectasis of the left lower lobe. And then they got a CT scan for better visualization, which I have for you guys. So I'll go ahead and start screen sharing that, and then I'll share the read after. Alrighty, can you guys see that? Okay, is that coming up for everybody? Cool.
Lizzie, I think the easy thing to do is just be distracted with what's happening in the left lung. You also want to analyze the right lung. Of course, it would be helpful if I could scroll up and down, but what we're looking for is like differences in Hounsfield units. And you can clearly see that area that you have marked out has a different density, meaning it's less concentrated and more like air than the area surrounding it, which I imagine is the lung parenchyma. But again, like it would be nice for me to be able to go up and down through this CT scan to see the different layers, because right now it almost looks like a balloon, the fluid. But why don't you give us the interpretation of the radiologist?
Sure, let me see. So the radiologist said that this is a large multi-loculated left pleural effusion with peripheral enhancement likely reflective of empyema.
Okay, so maybe we can go back to the whiteboard. And yeah, that was interesting. Like the way that fluid was appearing, it makes sense that it wasn't a simple effusion and there was probably loculation happening. And I think that this is really interesting because this has been going on for 3 weeks. Now, young people can get pneumonias for sure, and a complication is an empyema. And I think you can look at this case from a very simple lens, and that's the following: young person, healthy, here with subacute hypoxemia and inflammation from a complicated pleural parenchymal process. And the neutrophilia is helpful because, in fact, the white count is helpful. Even before you gave the CT scan, it pushed me away from lupus, as did the thrombocytosis. So, like, we know that white count and neutrophilia is consistent with likely an infectious process, and the thrombocytosis is consistent with a subacute inflammatory process. Typically, when we have organisms like strep, staph, and such, we actually often see a thrombocytopenia because the infection is quite acute and it may be associated with DIC. I think really what the next steps are, and the albumin is low because it's a negative acute phase reactant, is in addition to the broad spectrum of antimicrobial coverage, like making sure you target staph, strep, and anaerobes, you want to do a thoracentesis. And the thoracentesis is for not only a thoracentesis, you may even have to place a chest tube in this patient because they have like this multi-loculated effusion. So the thoracentesis hopefully will help the lung re-expand, improve the oxygenation. But when you're concerned for an empyema, it almost is like a purulent joint or an abscess. Like source control becomes key. And
No,
so
not.
oh yeah, so in this individual, I think the next steps is to get IR or CT surgery or interventional pulmonology, whoever does this at your institution, to go in there and drain these. And sometimes they even need, I don't know if you've seen this, Robbie, like multiple tubes in the different loculated areas. So right now, I think we're running towards empyema, and empyema, staph, strep, less commonly anaerobes. We have the antibiotics. Now we need to do the source control. And we already can anticipate what that pleural effusion should look like. And maybe because we're coming up on our break, what the audience can do is talk about what they anticipate the pleural effusion to look like. Think of the glucose, the LDH, the cell count, everything, like the pH. How would you predict? Because then if it's not consistent with that, then we have to step back and be like, hey, are we missing something? So maybe that could be a good pause, Robbie, for the audience.
Yeah, the breakout rooms are ready to rock and roll. So
speculate on that.
there you go. Open it, and we'll see you all back in about 5 minutes or so. Okay. All righty.
Alrighty, so great discussion. I'll go ahead and give you guys the results of the thoracentesis. Well, we actually had to put in several chest tubes, like we predicted, just because the empyema was so large, or like the collection there. And so the pleural fluid had a turbid appearance with frank pus. The pH was 8.5. And the cell count was 139,000 white blood cells with a 98% neutrophils, 2% lymphs. There were 3,500 RBCs, and her protein was 3.3. The glucose was less than 15, and the LDH greater than 1,200. And then that's the end of this aliquot. And after this discussion, I'll reveal the final diagnosis.
Professor, I'll take a quick crack at it. And I think whenever you see frank pus, you're probably you have a very, very high chance of this being an empyema. The diagnosis of empyema is really a formal diagnosis when you see frank pus or when the culture is positive. And I think the question here is there anything that casts doubt on the diagnosis of an empyema? And I think that it's not the neutrophilia, which is consistent with empyema. It's not the high LDH or the low glucose, which are consistent with an empyema. It's the high pH. We typically expect a low pH in patients with an empyema, typically less than 7.2. So I'm really curious, Prof. Rez, how you're thinking about that pH and any other things that strike your fancy.
I think you set up an answer for this that is naturally given to the way you set the question up, which is like when you have all these data points pointing to one direction, you sort of just neglect, like don't put too much emphasis on a single data point. Like I actually don't even know why the pH is lower. That's something I have to, I'm going to look up. I think from a pathophysiologic perspective, it's probably going to be really cool. But it doesn't dissuade me, Robbie, one bit. Like we have inflammation, leukocytosis, everything is consistent with an empyema. Like this is an empyema. And I think the question that you brought up during the pause that was not recorded was like, why this patient? You know, like I, I, I mean, young people get pneumonias for sure, and the most common reason for pneumonia is like acerating some, oral bacteria. But this is when the social history might be relevant. You know, she's exposed to this plastics and like probably dust, and having this like inorganic material go into the lung. I wonder if they're, and now this is all just speculation, whether that caused lung injury and just made her more vulnerable to the inability to clear bacteria from the respiratory lining. And I mean, only Lizzie will tell us at the end of this if there is some connection, and if that's the vulnerable factor that may have complicated the pneumonia to an empyema. And another thing is that this patient is going to need probably 6 weeks of antibiotics, and most likely it's going to be augmentin and then follow up imaging. But Robs, what else you got to add, my friend?
Absolutely nothing, Prof. I love that you're teaching us one of the most powerful tenets of clinical reasoning, which is it's a sum total of probabilities, and no data point will counterweigh the other ones. Yeah, I'm on the same path as you are. All right, Lizzie, tell us more.
Alrighty, so we ended up sending the pleural fluid for culture, and the culture grew Fusobacterium. So our final diagnosis here is Fusobacterium pneumonia complicated by a loculated empyema. Because Fusobacterium can be tied to Lemierre's disease, we ended up doing an ultrasound to see if there's any IJ thrombi, and that was negative. When we asked the patient more about what might have been going on, she did disclose that she had a tooth abscess like a month ago, or a month before presenting. And at the time, like she got it cleaned out and everything, but they didn't give her antibiotics, so she took a natural remedy instead.
And well, Lizzie, that's awesome, and there's no reason to anticipate asking that question, ahead of time. But I wanted to play a guessing game here, and don't give us the answer yet. Robbie, what species of Fusobacteria? I still don't. I don't remember it. I know, but you love this. Tell us the difference between the species, my friend.
Oh my gosh, Prof. Rez. I hope hopefully I fall flat on my face, and my best guess is that Lizzie doesn't have the species at hand and is frantically looking to find it right now based on her body language. So fingers crossed that's the reality of the circumstances. Um, I just wanted to, one thing I want to emphasize is like whenever you're dealing with a pleural infection, keep an eye out for anaerobes. And remember, Fusobacterium is a notorious, very bad anaerobe. So I think that point of and how does it change your empiric antibiotic strategy? Anaerobes, anaerobes, anaerobes. Because you probably waited 2 or 3 days for this to come back. It grows very slowly. So you could easily have this patient be on regular pneumonia medications without the anaerobes and the patient be not getting better. There are 2 types of Fusobacterium that I'm aware of. One is Necrophorum, which is usually in otherwise young, healthy people. The one to look out for, which is really bad, that Prof. Rez reinforced on RLR CP solvers, is Fusobacterium nucleatum. Nucleatum is associated with a high rate of underlying GI cancers. Nucleatum usually causes abdominal disease, and Necrophorum usually causes oropharyngeal and and pulmonary disease.
Lizzie, have you watched Gladiator?
No,
You
I
have,
have.
man, we're too old for this crowd. So you have my assignment to you is go watch Gladiator this weekend. And there's a scene where Russell Crowe looks into the stadium and he's like, "Are you not entertained? Are you not in?" After he like kills someone. And so I think that would be the best background music when Robbie discusses. He's about, "Are you not entertained?" He did this during one of the RLR episodes, and I was like, wow. And I didn't have it at hand either, but he guessed it correctly. So did you find the species?
I was looking, I haven't found it. Sorry.
Yes. So it's up to you guys to decide, are we right or are we wrong? And there will never be a right answer. Thank you for trying though, Lizzie. We really, really appreciate it. I'm really curious. I don't know if you're involved in this patient's care or not, directly or indirectly, but putting together this case certainly was very educational for you, I imagine. What are the things that you learned from this experience?
So first I thought like I'd never seen a Fusobacterium pneumonia before, so I like had to do some research on that. And pneumonia caused by Fusobacterium with an empyema is increasingly associated with like immunocompromised states. So we were kind of like barking up the right tree there in the chat, and in the discussion. So she didn't have any immunocompromised factors at play, so it was pretty weird that she got this even with the oral abscess. And then I just kind of learned more about like you have to treat it with like a medical and a surgical approach. So you have to like drain the empyema to get that source control and then use like antibiotics for anaerobic coverage and all of that. And the treatment is usually for like 4 to 6 weeks, which was a long time, I thought. But those were the main takeaway points I got. And also just trying to get a really thorough history to understand what brought the person into the hospital.
Yeah, Lizzie, I think the field of internal medicine is super lucky to have you. You presented this case with such poise and such equanimity and with a lot of confidence throughout. And yeah, like, I'm very, very excited for your future. Hopefully, we get to hang out with you more on VMR. Alec, I know this is round two of you mentoring, and we've learned a lot. Prof. Rez, Alec and his student colleague yesterday brought us a case of another pleural effusion, and I don't want to spoil the answer in case folks haven't watched it yet, but it was a mesmerizing case of a different cause of a pleural effusion. I'm curious, Alec, if you have anything that you wanted to emphasize before we pass the mic to Ibrahim for teaching points.
No, thank you so much, Lizzie. Great job. Lizzie actually saw this patient all on her own on her sub. I actually never met this patient, so I just helped to sort of helped with the aliquots, but she did it all on her own. And I think if I remember right, it was necroform. It wasn't nucleatum, but I could be wrong there.
Pause right there, Alec. Pause right there before you continue.
But yeah, I don't have too much in the way of reflections, except to say, grateful for the space. And, hopefully today was some space learning from yesterday from all that we're able to join.
Is this not why you're here? Can I ask all of you guys, like anyone here, but especially to Prof. Rez, Alec, and Lizzie, what did you guys, since we have a minute or two, what did you guys make of the pH? Is it really, are we following Prof. Rez's advice and applying the reality of clinical reasoning and saying it was noise, or were there any reflections that you all had on it that we can learn from it, or is it really just a distractor?
I think when we saw the patient, it was just kind of like, this is probably just noise. We didn't think too much of it just because it was like so clearly empyema. But it's a good point. I'm not sure what to make of it now.
Well, I will try to do some reading. Prof. Rez, I've never been able to in real life get an actual pH off of pleural fluid because you send it off to the lab. There's some processing error or whatnot. I wonder if it's that, but yeah, I'm really curious to try to read more about it. It definitely is such an extreme outlier.
The only other thought I had as well is, and Lizzie, I'd have to confirm this with you, is like, how long was the patient actually on antibiotics before they stuck in the chest tubes? And whether or not the pH would have been affected by a few days of antimicrobials or not. But beyond that, yeah, frankly, when we were writing up the case together, we thought it was a little bit weird, but we had no real explanation for it.
And I just want to say, I appreciate you guys keeping it real. Like, it's really important for the audience to keep all the data real because oftentimes there is an explanation when you search deep enough. And so I just wanted to thank you, Lizzie, for keeping it authentic and not trying to make up values that are consistent with the specific. That's really important, not only writing cases, but presenting cases.
All right, last but not least, Ibrahim, take us home.
Thank you, Professor Wells, and thank you, Ravi, and thank you, Lizzie, for this great case, and thank you, Alec, as well. How we studied this case was basically with the chest pain, the shortness of breath, and the hypoxemia. And Ravi has taught us a lot about each of these three different categories in here. And so if you have a patient who comes in with chest pain, this is typically a benign etiology in 90% of these patients because chest pain has a very wide differential. So it can range all the way from an MI to a musculoskeletal cause. However, if you have a patient who's presenting with a shortness of breath, then you may want to be more alert because it can be more acute and severe. And typically, shortness of breath would indicate dysfunction inside of the chest viscera itself. And then especially if it's severe. So benign etiologies can include deconditioning and panic attacks, but you should always have your alert there. And then finally, for the hypoxemia typically happens because there's something wrong between the alveoli or the blood vessels. And so you can think about it in terms of a molecular level. And so the alveoli itself, it can be filled and it can be also collapsed. And in either of those cases, it could result in hypoxemia. And for the blood vessels, you can have a thrombus that blocks the blood vessel, or you can have shunting due to an AVM malformation, for example. And then we heard also that the patient had fever and chills in addition to their hypoxemia. And so this points towards an inflammatory thoracic visceral disease. And then in a patient who's young and she has no past medical history, you really want to think about three main things that Professor Reza has taught us about, which is the immune status. If this patient had an HIV, for example, or if she has an autoimmune disease, such as SLE, and you also may want to dig deeper into the occupational exposure, because here you have increased pretest probability of pneumonitis, or it may even make someone vulnerable to an infection. What you would start next in this patient is empiric antibiotics. And then you would also want to get a thoracentesis. However, before you get the thoracentesis, we heard that this patient had decreased lower left lobe breath sounds. And so here, because of this patient presentation, we started thinking about the pleura. And so you can think why the pleura would not be able to expand in such a patient. And that is because it can either have air or fluid inside of it. If it has fluid and the patient is presenting with a similar presentation to this patient, you really want to think about empyema until proven otherwise. And you want to give patient piptazo or ampicillin sulbactam plus a gram-positive coverage. And this is because you want to cover for anaerobes because air cannot get into the pleura, or because there could be a possibility of an abscess. And then you may also want to consider CT angio, just like Professor Reza has suggested. And then finally, we heard also that the patient had leukocytosis and thrombocytosis, which made us even think much more consistently with infection, specifically a subacute infection, because thrombocytopenia would be expected in an acute infection, but a thrombocytosis would be expected in a subacute infection. And finally, Rabih has shared with us some interesting pearls regarding Fusobacterium, where you have two different species. You have the Necrophorum, and you also have the Nucleatum. The Necrophorum is usually in healthy and young individuals, and it usually results in pulmonary and oral disease, whereas Nucleatum could be associated with an underlying GI cancer and would typically cause an abdominal disease. And with that, I think I'm done with my teaching points for today.
That was an incredible job, Ibrahim. The only Robbie was going to give you some positive feedback, but I muted him so I could be the one who gives you feedback. And I love the smile at the end. But thank you so much, everyone. Robbie, Lizzie, Alec, Ibrahim, and who scribed today? We got to thank the scriber. Who scribed today? Oh, Zachariah, thank you. Thank you. I'll send you some pictures, Zachariah. I know you like it when we put pictures on the website. Robbie, any other comments to make before we end the session? Lizzie, come to UCLA. It's a good place.